So new headset, hopefully this is actually going to work better. Um, so a little bit about the schedule, and then we'll talk a little bit about the final as well. Today, what is the 6th? So you guys had exam 5 here. In terms of lecture, we're going to do endopatho. Okay, that's going to be the last major lecture for kind of final stuff. Tomorrow, when I see you guys, you have quiz 14 now. That's over endo, phys, and patho. Okay, the key to this quiz is just the phys, right? Like as I was talking about, hey, growth hormone. If you know what growth hormone does, you can answer any of the pathos. What happens if you have too much growth hormone? What happens if you don't? Okay. So I would say the key there is definitely phys. And then lecture will be muscle, skeletal, and integ. This lecture here, this is just our fun lecture. This is our last lecture. This is more of a primer for foundations. It's just like show up, have fun. This is what I have my master's in. This is what I like. There's 2 questions, 2, 3 questions on the final from this lecture, which I will just straight up tell you. So tomorrow's lecture, chill, relax, have a cup of coffee, laugh with me. That's the goal. Then that brings us into the next week there. Next week will be kind of like a review day. Okay. And actually, sorry, I did that in the wrong order. You'll have a quiz. Oh, Lord. You'll have quiz 15. That's over muscle skeletal intake. And again, I'll tell you guys, hey, I'd probably star that kind of thing. Okay. Not really trying to make this stressful. And then we have kind of like a quote unquote review day. Okay. For the review, I have a proposal of sorts. Okay. So you guys have gotten an email about end of quarter reviews, right? Probably. All right. So I just want to show you guys that way it's like 100% transparency because I don't believe in that weird shit. All right. So when you guys do a review, this is literally what I see. I get a list of links. You guys are cohort A. Okay. Oh, I'll just do it right. I click on cohort A. Boom. Y'all are breaking my heart. This is all I see. I don't see any names. I don't see any actual information. Okay. Now, here's what I propose. By tomorrow, so you can do it tonight. By tomorrow, if we can get this to 95% or better, if I can get a 95% response rate for these reviews, we will hold a kick-ass review, including a practice exam. Exactly. It won't be, no. It'll be like, I'll be writing a separate practice exam. So it won't be like exactly the same, but the material will be there. And I'll make sure on the practice exam, we go over some tricky questions that might be similar on the final exam. It should be an emailed link to you guys. Other folder. Okay. So a little bit of like the little asterisks here. Little bit of an asterisk, 95 response rate, not a 95% approval rate. Okay. I'm going to pick on poor Ashley here. Let's say Ashley just absolutely hates me and wants to tear me a new asshole. That's fine. I don't know. I won't see this. Okay. Again, I won't actually see, I don't even see any students' names. The only time I actually can finally see my reviews is after I've submitted final grades. Okay. The reason why I kind of push on this here, back in the day, I used to teach for CU Boulder. One of the things when I was like looking at other teaching jobs after that, one of the universities asked for every single eval I had ever received while teaching. I actually take these really seriously. Like, I don't know if you guys can, like, the computer, the tech, the class, the way I have you guys draw and orientate things, that's all by the byproduct of student feedback. Please let me know what you liked. Did you like the fact that I could pre-record lectures? Because that was like one of the biggest things that students were like telling me that they wish they could have. Let me know what you liked, what worked, what didn't work. Okay. Just because I'm not perfect and I'm always trying to improve. So, and I need your guys' help to do that. I do take these seriously. I have an entire filing cabinet at home for all of my reviews. So I am looking for genuine, candid feedback. You know, I'm not, again, this is a 95% response rate, not approval. Okay. But please, if you can, provide me feedback, what you liked, what you didn't like, what worked, what didn't work, so I can keep kind of changing things up. So after that whole spiel, deal or no deal? Okay. So we'll check tomorrow morning. It doesn't update for like 12 hours. Okay. Again, don't feel like you have to do it right now just because I do want that genuine feedback. Fuck you. Didn't take that long to write. Well, don't set your standards too high. Okay. All right. In terms of the final, okay, you're looking at 50% endo, 50% cumulative. Okay. With the endo, you're looking at phys and patho. Okay. Your final is give or take about 60 multiple choice questions. 60 multiple choice, and you're looking at 2 essays, like legitimate kind of essays, still kind of bullet points, but I would say these are probably going to be more of an essay than what you guys have traditionally had. Okay. There might be some fill in the blanks. Obviously, I haven't even gone there yet, but 50% endo, that means 30-ish questions regarding endophys. So what you just did for renal, that's what you're doing for endo. So you're basically doing like a shortened exam with endo and then 50% cumulative there. Okay. Yes. What I'm going to do is I'm going to set a bank for endo, and then I think I'll set a bank for cumulative. So that way you can have all of your 30 endos first and then 30 cumulative. That's my plan. Again, with the endo, you guys have that packet. I have some paper copies, but they printed wrong. Does anybody want paper copies? I'll go print some off during break. Okay. I just needed rough handage. Yeah, remember that endocrine packet that we had where we kind of drew everything out and I gave you guys the answers for all that? This, who wants a paper copy? All right, I printed these off wrong, so I'm going to reprint them during break. I just need kind of like a rough estimate to see how many I need to print. So I'll get those reprinted during break. Again, the key to patho is the phys. Okay, you guys kind of saw a little bit. What happens if someone doesn't have antidiuretic hormone? What happens if somebody has too much aldosterone? That's where that patho lives. Okay, for that cumulative stuff, I'm going to help you narrow it down. Hang tight with me. I'll explain everything tomorrow. Okay. I'm just really hoping for that 95%. But no, I still will help narrow things down there. Sound good? Questions about the final? Yeah, great question. So one essay will be endo, one essay will be cumulative. And I will probably tell you what this will be. Let me sweeten up the pot a little bit. Get that 95%. I'll tell you the 2 topics that I choose from for the endocrine path. So that way you can study for both of them. Okay. Oh, time. Your final will be on Tuesday. Okay. So this review day will be online. So we're gonna, so this is the last Monday that we're meeting in person. Sorry. No, I'm kind of sick of these Mondays too. Final will be in person on Tuesday. Now, here's the question. The final 60 questions, you guys used to have about an hour 15. The final, you have 2 hours. As a class, vote. Do you want to start at 8 or would you like to start at 9? We'd still be done by 11. In favor of 9? Okay, so let's do 9 o'clock. But I'll be here at 8 if you guys have questions. I'm just kind of, I'd like to be over prepared. So we'll start at 9. 2 hours is what you have for the final exam. When you're done, you're done. Walk out of here, light a fire. I don't know, whatever you want to do. But yeah. And then my goal, obviously, just like we were doing, like you guys are used to, I'm pretty quick about grading. I'll have your finals graded as they come in. So hopefully I can post final grades Tuesday night. Okay. Any other questions? That's good. Okay. Yeah. I'm glad you asked before I just like discarded everything. Yeah, I can definitely do that. Okay. Cool. So endocrine pathologies. Remember all those crazy hormones that we talked about? There's quite a few, yes? In theory, all of your pathologies is either too much of a hormone or too little of a hormone. All of those hormones that we covered, we're not going to be going over a pathology for all of them. So this is only a shortened list, if you will. Okay. Again, all of the pathos is either too much or too little, hypersecretion versus hyposecretion. Okay. 2 ways in which somebody can have a hypersecretion. First method here is going to be a benign tumor on the organ. So take, for example, we'll use today's essay, renin. Renin comes from your kidneys, right? Somebody who develops a benign tumor on their kidney would secrete too much renin as a result. Okay. Second way to have hypersecretion is a broken negative feedback loop. Okay. What was the whole point of the negative feedback loop? Achieve homeostasis. And we do that by shutting off the beginning steps. If I break that, my beginning steps aren't inhibited. Okay. For hyposecretion, 2 ways to kind of go about that. It can be an autoimmune issue, an autoimmune attack on the organ. Okay, we'll talk about Hashimoto's, a form of hypothyroidism, where you go after your thyroid. Diabetes type 1, you're going after your pancreas. Okay, second one is going to be trauma/surgery on said organ. Okay, if I cut somebody's thyroid in half, how much thyroid hormone would you expect that they make? Yeah, half of what they used to. Okay. So with a hypersecretion, would you expect a greater response or lowered response? I would expect a greater response. Hypo, therefore, would be a lowered response. Okay. All right. So starting at the very top, we talked about the hypothalamus. Okay. So we're going to be kind of talking about that issue there. First up is the infundibulum. Does anybody remember the infundibulum, what that was? It was like a bridge. Yeah. It connects your hypothalamus to your pituitary, your and your postpit. Okay. So your infundibulum is that physical connection between the hypothalamus and the pituitaries. We talked about if you knock this out, if you have an interruption. So these are all different types of damage, ways to damage your infundibulum. Let me say you do not need to memorize these. Okay. All I'm talking about is if you damage your infundibulum. If you damage your infundibulum, what happens to your ability to communicate to the pituitaries? So no pit communication. What happens to your pituitaries if you don't talk to them? Yeah, they shrink. Yeah, absolutely. I saw the hand gesture, so I was like, you got it. They're going to cause pituitary atrophy. My pituitaries are going to shrink. And if my pituitaries shrink, what happens to their functions and secretions? Decreased function and secretions. Okay. So again, kind of talking about this, the infundibulum. This is that physical connection between the hypothalamus and your pituitary. Knock that out. You can't talk to your pituitary anymore. It shrivels up. It stops working. Okay. How many hormones came from the pituitary? A lot. 7 up or 6 up front, 2 in the back. This is what's going to lead to pan-hypopituitaryism. Pan. Does anybody remember pan? Yeah, like pancytopenia means all. Hypo, lowered. Pituitary, pituitary. Ism is function. So if I knock out the infundibulum, I get to look forward to pan-hypopituitaryism. All of those hormones go away. Okay, so these ones and more. So let me just say like all ants and post pit hormones decrease. Hormones like growth hormone. So if somebody knocks out their infundibulum, what's going to happen to their growth? Stunted growth. What's going to happen to gamete and sex hormone production? What's going to happen to your thyroid? What's going to happen to your adrenal glands? Everything goes down. This is actually a pretty terrible disorder. It's one thing if somebody's missing one hormone. It's another thing if they're missing 8. Okay. If we're lucky and we just damage the pituitary, you might have hypopituitaryism. Hypopituitaryism. What do you think the difference between pan-hypopituitaryism is and hypopituitaryism? Hypopituitaryism is just one hormone is deficient. Okay. So with hypopituitaryism, you're only missing one hormone. Okay. You don't need to know these. These are the different causes, but I'll talk a little bit about Sheehan syndrome. You don't need to take notes on it. Sheehan syndrome affects women who have just delivered a baby with a very complicated birth. Baby delivery, there's blood loss, yes? Some women lose so much blood that this causes their pituitary to necrose. So they can lose one of these hormones, if not all of these hormones. Particularly dangerous because pregnancy, delivery, and the stuff that comes after, it's a hormonal roller coaster. If you are missing one, oh, you're on track for a crash. Okay. So that's just if anybody's like interested in obese stuff. All right. So now that was just the connection between the hypothalamus and the pituitary. Now we're talking about the pituitary specifically. Hormone I want to focus on is growth hormone. Growth hormone. So either you have too little or too much. The effects depend on what age these kind of onset. So it's childhood versus adulthood. Okay. Now let's think. If a child doesn't get enough growth hormone, you guys have probably heard of this. What disorder usually develops? Dwarfism. So this is one of the versions of dwarfism. Okay. And what happens if the kid eats their Wheaties and gets way too much growth hormone? Gigantism, yeah. Okay. The why, children have a growth plate. You guys know the epiphyseal plate in the bone. Okay, i.e. the bone's still cartilage. If I give too much or too little growth hormone, the bones can still change their size. As adults, do you have any cartilage left in your bones? It's all calcified. Okay. An adult without enough growth hormone, that'll cause metabolic syndrome. Metabolic syndrome. Anybody know when an adult gets too much growth hormone? Andre the Giant had this. Acromegaly. Acromegaly. So just a little chart to kind of help you guys out here. Again, all of these pathos, too little or too much. Okay. All right. So starting with the hyposecretion of growth hormone, dwarfism, it's going to be in adolescence. Metabolic syndrome, this is a collection of risk factors that increase risk for coronary artery disease. Diabetes type 2. Okay. So metabolic syndrome, hyposecretion during adulthood. Okay. If somebody has a lowered metabolism, are they using or storing their nutrients? Storing. This person's going to end up storing all their fat. That's why they're at risk for heart disease. This is why they're at risk for diabetes. It's just their metabolism is too low. So let's think about this. As a nurse, if somebody has hyposecretions of growth hormone, how do we fix this? Yeah, easy enough. Supplement with growth hormone. Usually the hypos are the easy ones to fix. What hormone are they missing? Let's just give it to them. Okay. So this here, child growth hormone deficiency. Okay. They're tiny. Their growth plates aren't closed, but if I give her growth hormone, she'll be back on track. All right. On the other side, hyperpituitaryism, elevated functions of the pituitary, can be caused by a pituitary adenoma. Oma. What do you know about it? Benign. And if we have a benign tumor growing on an endocrine organ, what happens to secretions? Okay. These are some of the manifestations, some of the symptoms. Headache, fatigue. Okay, let's think about this. Why would somebody have headache and fatigue? There's a benign tumor in their brain. Okay. Visual changes. Why might I go blind? There's a tumor in my brain. Tumor in brain. Okay. It's going to press on the optic nerves, press on that optic chasm, because your pituitary is right between your eyes. Okay. What's interesting about it is if you have a benign tumor, this causes you to hypersecrete one hormone, but then you neglect all the other hormones. Okay. So hyposecretion of, so hyperpituitaryism, excess of one hormone, deficient in others. Okay. So it's almost like you start sacrificing your other hormones for that excessive hormone. Okay. So hypersecretion of growth hormone, you guys called it gigantism in children, acromegaly during adulthood. So this gentleman here, I believe, still holds the record. I could be wrong. Big dude, yeah. This is your standard Monopoly man for scale. Doesn't he look like he came from the Monopoly box? Like top head. Okay. This dude was huge. What I remember was this is when they first started coming up with automobiles and things like that. They actually had to take out the driver's seat so he could drive from the back seat to fit in a car. Okay. So I would say almost 8 feet. It was stupid. It's like 7'9". It's a big boy. So keep in mind that's gigantism. This is acromegaly. What are your differences? What are the differences you guys see? We got big feet. Absolutely. Fun fact. Anybody know what size of shoe that is? 26. These are custom made shoes down in from Australia. All right. So we got big feet. What else do we notice? Big hands. Yeah. Do you guys see the same kind of facial? So here we're going to call them facial enlargements. We have a forward brow, large nose. Do you see that with gigantism? Okay. Because again, the growth plates are calcified. We can't expand the bones anymore. With gigantism, things still look proportional. With acromegaly, we do have the increased height, but the proportions are a little different. Okay. So here, these are two patients with acromegaly. Here we have a child, 9, 16, so on and so forth. At what age did this child develop a benign tumor on their pituitary? Somewhere between 16 and 30s, right? At 16, doesn't seem disproportional. Everything looks fine. Yeah. Here we can kind of start seeing the nose starts widening, the brow starts coming forward, the cheeks become bigger. Yeah. So yeah, this gentleman here, his hand is bigger than her face. Like that is the face of confidence right there. Okay. Um, some symptoms of acromegaly. We had mentioned enlarged hands and feet. I'm going to say enlarged facial features. Enlarged facial features. Now, one of the other things, if you guys kind of notice about the fingers, what do you guys notice there between the fingers? They're a little thicker, yeah? This means you're going to have limited range of motion. Limited range of motion. Okay, so they're not going to be nearly as dexterous as the average person. They're going to have a lot of joint pain, so movement's going to be difficult. They can have some bodily odor issues, like they just make too much BO. Okay. The other one that's more kind of important, enlarged organs. Their heart is going to be bigger. Their lungs are going to be bigger. Their liver, their stomach, everything's bigger. Why is that a problem? Can't get blood. Yeah, getting blood around perfusing is kind of tough. Absolutely. And we'll kind of going to come back to that. What else is going to be an issue if your heart was too big? It's still a lot of muscle. Kind of. How much space do you got in your rib cage? If everything's enlarged, your heart can't properly fill. Your lungs don't fully inflate. Everything's too squished in there. So you can actually see limited organ use. Okay, like their organs are just compromised. It can, but the organs on the inside are getting bigger more so than the rib cage. Yes, you got it. Question for you, a little bit of cumulative application here. Why? There we go. Why do people with gigantism slash acromegaly have shorter life expectancies? Why do people with gigantism or acromegaly not live as long? Bodies are working hard, the heart can't keep up. There's more resistance. So what I'm getting at is increased length leads to increased resistance. That means the heart has to work harder. So I'm going to say increased resistance means decreased cardiac output. Okay. So in a person with acromegaly or gigantism, what organ's most likely going to give out first? The heart. Okay. Yep. Yep. Then the guy was, for his size, not quite an alcoholic, but the guy was known to like finish kegs by himself. Like Princess Brides, they ran out of beer on set because of him. The guy was awesome. Like he was never an angry drunk, which was cool. All right. So another hormone that came from the pituitary we talked about was prolactin. Anybody remember what prolactin does? Lactin. Movie milk. There we go. You can use those quotes. Okay. Caused by prolactinoma. So, hey, look, here's your context clues. Oma, what do you instantly know about it? It's a benign tumor causing someone to release too much prolactin. So, someone who has prolactinoma, guess what they're doing all the time? They're making milk, they're leaking milk. Now, when women, typical women, start producing breast milk, that's usually denoting near the end of pregnancy, if not just right after childbirth. Yes? If this happens, that's the state your body thinks you're in. So if you just give birth, do you want your period? It's going to stop your period. So amenorrhea, that's the cessation of the menstrual cycle. Galactorrhea, that is milk production. Galactose is a sugar that goes into milk. Okay. Hirsutism, you guys know that one from health assessment, hair growth, but not in any of the fun places. And then osteopenia. See, I'm not a nurse yet. I can actually get away with these kind of descriptions. Osteopenia, what's happening? You guys are never going to forget penia either. Bones are lacking. Why would someone's bones be lacking if they're making breast milk? All of that calcium is going into that breast milk. Again, the whole problem is the body thinks it's basically, I'm just gonna say pregnant slash just delivered. Okay. Breast milk, absolutely. And that's the thing is you have this benign tumor on your pituitary. You could start producing breast milk. You could start producing growth hormone. You can start producing too much thyroid hormone. This one tells you that this is a tumor causing you to produce too much prolactin. Okay. Don't worry, guys can jump in on the fun here. This can happen to dudes. Hypogonadism. This is when the grapes turn into raisins. Erectile dysfunction, the kind that pills don't fix. Oligospermia just means you can't produce any sperm, i.e., hey, if this happens in males, the male body thinks it's pregnant. Okay. So I'm going to apply that down there as well. What is the one population where this wouldn't be an issue? I don't want my child making breast milk. It's weird. It could still affect children, but when would this be helpful? When would it be helpful to not a problem for pregnant people, individuals? Okay, so this is not going to be a problem if someone actually is pregnant. However, if you think about your life, do you spend most of your life being not pregnant or pregnant? Problem for most of the time. Agreed? A lot of them do. A lot of them do. It's a great weight loss plan, by the way. Just saying, like postpartum, you get to eat more, but like breast milk is straight up black magic. It can change its contents during the feed. It can be high carbs, high fat. You need more vitamins. Hey, you want some antibodies with that? Like, all right. So now we're moving to the post pit here. Remember, again, your ant pit, we talked about 6 different hormones. We only went over 2 pathologies. So it's not that bad. With post pit, we're going to be talking about ADH, antidiuretic hormone. You guys know about this, yes? Somebody with SIADH, syndrome of inappropriate antidiuretic hormone. SIADH, i.e., they make too much antidiuretic hormone. Sorry, I didn't come up with these names. Okay, so hypersecretion of antidiuretic hormone. What's the problem with that? You're going to be holding on to water, right? Because antidiuretic hormone makes you reabsorb water. Anything else or just water? Antidiuretic hormone? It's only water. Only water. Increase water reabsorption. It doesn't affect your electrolytes. So I'm only reabsorbing water. When I'm reabsorbing, I'm going from what fluid to what fluid? Urine to blood. So let's think about symptoms. That means I'm putting a lot of water into my blood. That's going to be water in the urinary tract already. That's past the nephron. Can't really do anything about it, except, again, the water is all in your blood. You might have hypertension, sure. What's going to happen to your electrolyte concentrations if you're only reabsorbing water? Hyponatremia. What about potassium? Hypokalemia. What about, I don't know, albumin? Hypoalbuminemia. Here's a weird one. What about glucose? What's going to happen to glucose concentrations in the blood? It's going to decrease as well. Hypoglycemia. Hey, if somebody has SIADH, their blood is way too dilute. That's your water intoxication. Way too much water. So what's the issue with hyponatremia? Hold your wee for a wee. Why is that a bad idea? Let me say, yeah, I'll just do increased ICP, increased intracranial pressure. What's the issue with hypokalemia? Let's say dysrhythmias. Hypoalbuminemia. Issue? Edema. Hypoglycemia. We'll talk about diabetes here. Hey, you're looking at seizures. Problem? Okay. SIADH can be a very lethal endocrine pathology. What do you think their urine output is? It's pretty low because they're reabsorbing all of their urine. So here's the hard part. What's treatment? Maybe we give them diuretics. That might help. That's a good idea. Yeah, we can definitely. I mean, we're going to be giving a lot of electrolytes constantly. The problem is your posterior pituitary. Yeah, you might have to cut it out. You might have to cut it out. Okay. This is a pretty rare disorder. I think there's like 16 documented cases thus far. So, it's absolutely crazy when they want to do pituitary removal. So take for example, if I have a pituitary adenoma, what they'll do is they'll either go through the nostril, like straight back, or they'll go through the soft palate. So you ever see like what they do to the mummies, like they kind of like squish their brains out through their nose, kind of like that. All right, now we're talking about diabetes. I am Wilford Brumley. I have diabetes. Okay. Two types of diabetes, but not probably the two types you guys are aware of. Diabetes insipidus versus diabetes mellitus. Diabetes mellitus is the one you guys are probably more familiar with. That's where you have the type 1 versus the type 2. We're going to be talking about diabetes insipidus. Okay. Diabetes insipidus is caused by too little anti-diuretic hormone. So the difference is here. Anti-diuretic hormone comes from which organ? Posterior pituitary. So this is a problem with the post-pit. Somebody has type 1, type 2 diabetes. What's the problem organ? Pancreas. Problem with the pancreas. Now, what these both have in common, the reason why we both call it diabetes insipidus or diabetes mellitus, what they have in common is you see increased glucose in the blood. Increased glucose in the blood. Okay. So diabetes insipidus, I would say know this one well. I like to ask questions on it. And when I was observing in peds, this was just a random question she just dropped. Okay, so this one's probably worth noting. Diabetes insipidus, exactly as it sounds, insufficient ADH. Now kind of translate that. You have insufficient or not enough anti-diuretic hormone. That's a double negative. What's the issue here? Urinate excessively, i.e. no water reabsorption. Okay, polyuria. You guys have heard of that one yet? Many urinations. You're peeing a lot. Polydipsia. Do you guys know that one? Polydipsia is going to be thirst. Why would a person be thirsty with diabetes insipidus? They're peeing it all out. They're dehydrated. Okay. Hypernatremia, hyperosmolemia. What? Why would my blood get more concentrated with diabetes insipidus? There's no water. No water in blood. So what happens to sodium concentrations? Symptoms, increased sodium Potassium. Okay. What else would go up in the blood? Hmm? Chloride. What else? Albumin. What else? Calcium. Okay, what I'm getting at here is everything goes up in the blood, i.e., if this person doesn't get water in their blood, what happens to the viscosity? Super thick. This is why we call it diabetes insipidus, because hey, what will also happen to glucose levels? You'll see hyperglycemia. Okay. All right. So there was actually an interesting little like quasi documentary on a patient with diabetes insipidus in the UK. This person here had to drink, I believe, 30 liters of water every day just to survive. 30 liters. So give or take 20 of those on a normal day to survive. This isn't even being properly, adequately hydrated. Just survive, just like to live. Okay. Now, I always encourage you guys as nurses, try to empathize with your patients, try to understand what they're going through. If you had diabetes insipidus and you're drinking that much water, how often are you going to the bathroom? Yeah, you might as well sit in the bathroom. What does that mean for your ability to go to school, work, date? I mean, you hope so, right? So not only that, when's the point in your day? What's the period in your day when you don't typically pee? This person has to wake up every 2 hours at most to go pee. What would be your life if you couldn't sleep for more than an hour or 2 hours at a time? Horrible, depressed, angry, impulsive. That's probably why they're being a little mean. Okay. What would be the treatment for diabetes insipidus? The problem is they don't have enough. Let's just give it to them, right? Problem is we don't know how to make ADH. Don't need to write that one down. I'm just saying, like, we would give it to them if we knew how to make it. Drink plenty of water, Tim. You might have to do a Foley catheter so you can actually sleep for 8 hours, but then you're doing a Foley catheter every day, if not every other day. Risk for UTI. Condom cath can also work too, absolutely. Or they might even just have a external bladder, which they're constantly filling. Okay, so how does this diabetes insipidus kind of happens two ways: neurogenic versus nephrogenic. So think about like what we kind of saw with shock. If it's neurogenic, genic means causing. What's the problem? The brain. Insufficient amounts of ADH from the post pit. That's neurogenic diabetes insipidus. If we could make antidiuretic hormone, it would treat neurogenic diabetes insipidus. What if it's nephrogenic? What's the problem? This is when the kidneys don't respond to ADH. So I can pump this person full of antidiuretic hormone, but the kidneys aren't picking up the phone. What would be treatment there? If their kidneys aren't listening, maybe we need to give them new kidneys that would listen. Okay. All right. Now we're talking about the thyroid here. Now with thyroid, with hyperthyroidism, I believe there's like 11 different types of hyperthyroidism. We're only going to be talking about one. Okay. The one you're going to be responsible for is Graves' disease. So let me say hyperthyroidism is defined as excess T3, T4. But specifically Graves' disease, you have excess T3, T4, but minimal TRH and TSH. This is what makes Graves unique. You have too much of the end product, even though you don't have any of the beginning product. It's kind of weird. Okay. What happens is Graves is an autoimmune disorder. Autoimmune disorder. And you attack, let me say not attack, you target the thyroid with TSIs. TSIs. Okay, I know more acronyms. Sorry, I will explain what TSIs are and where they kind of fit in there. Now, somebody has too much T3, T4. What does T3, T4 control? Metabolism. That's your endophys. Now, if I ask you, what's the consequence of hyperthyroidism? You just got to go to, again, what T3, T4 does is the metabolism. So what kind of symptoms would you anticipate? We would see increased metabolism. You might see weight loss, absolutely. Now, what's something that you do? I don't, I should, I just don't have time. What should you do every day to increase your metabolism? Exercise. Think about your vitals during exercise. What happens to blood pressure? What happens to, or what other vitals change? Increased heart rate. What else? Increased respiratory rate. Thank you. Diaphoresis or sweating. Okay, weight loss. What about temperature? Increase in temperature. Okay. If somebody secretes too much T3, T4, hey, look, I get to lose weight. That's awesome. The problem is it seems like my body's working out 24/7. If my body is working out 24/7, what organ's at risk of giving out? That's what this is getting at here. So thyrotoxicosis, toxular nodular disease, is defined as, sorry, excess T3, T4 straining the heart. This is why we don't use T3, T4 for weight loss. There's no point in trying to lose weight for a week only for you to suffer heart failure. Okay. Now you might also see a goiter. Goiter. It's an enlarged thyroid. Why is my thyroid enlarged? Yeah, you're secreting too much T3, T4. Now, understand goiters are not unique to hyperthyroidism. Just because someone has a goiter doesn't mean it's hyperthyroidism. You can also see goiters in hypothyroidism. So this is a symptom, but not a signature symptom. Okay. You might see exophthalmos. This is going to be eyes bulging out, kind of like the perpetual surprised face. Okay. Thyrotoxic crisis is what we were describing there. That's your heart failure from too much T3, T4. Okay. So how does a person get Graves? Oh, look at that. It's a blank diagram where I'm going to write a mechanism. Odd. We have TRH that comes from the hypothalamus. That goes to make TSH at the ant pits. Finally get T3, T4 at the thyroid. Now T3, T4, once in a healthy person, once we have T3, T4, what happens? Let's going to inhibit TSH and TRH. Okay, so that's your normal, healthy, negative feedback loop. With Graves' disease, two important symptoms here: excess T3, T4, and minimal TSH, TRH. If you can remember these two symptoms, you can remember the entire mechanism. Okay. We're going to start with the minimal TSH, TRH. Okay. What ends up happening is Graves' disease. What kind of disorder was this? Autoimmune. This is going to have an autoimmune attack of T3, T4 receptors at the ant pit. I'm going to have an autoimmune attack of T3, T4 receptors at my ant pit, which means basically a wall goes up here. Wall goes up there. So T3, T4 get made. It goes to my ant pit. Does my ant pit recognize it? No. But what organ does recognize it? Hypothalamus, which is going to shut off TRH. If I shut off TRH, what happens to TSH? Minimal TSH, TRH. Okay. Second part to this, elevated T3, T4 comes from thyroid stimulating immunoglobulins. Oh man. Thyroid stimulating immunoglobulins. Okay. i.e., this is your TSIs. Now, these are immunoglobulins. Immunoglobulins, what are they? Antibodies. These are antibodies that target and trick the thyroid into making T3, T4. So this is what kind of makes it unique. TSIs. Normally antibodies tag an organ and we attack it. These tag your thyroid, but instead of attacking your thyroid, your TSIs stimulate your thyroid to make T3, T4. So this person here has a pretty broken negative feedback loop. Okay. They're constantly making TSIs, so they're constantly making T3, T4. By making too much T3, T4, hey, that shuts off TRH and TSH. This is Graves' disease. So, great question. I was going to ask you guys that. What would treatment be? Remove the thyroid. If the problem is that my whole system is being wonky because of my thyroid, take the whole thing out. If I don't have a thyroid, will I be able to make T3, T4 without a thyroid? No, but you can supplement it. Levothyroxine, if anybody's ever heard of that, or Synthroid. That's artificial T3, T4, or animal T3, T4. So i.e., the thyroid's a problem, take the whole thing out, break the loop. Now you can control it artificially with medications. Okay. Yeah. So here's your goiter there. This is your exothalamus. So for whatever reason, again, they look perpetually surprised. Okay. Part of it, I think, I was trying to find a good explanation for this. Um, from what I've been able to gander, the excess T3, T4 actually causes your muscles around the eye to get bigger and stronger, causing your eyes to open wider. That's my understanding of it. But this right here, unique symptom, signature symptom. Okay. On the other side of hyperthyroidism, we have hypothyroidism. Okay. Again, there are several different types of hypothyroidism. I'm only concerned about two. So I'm concerned about Hashimoto's. Not worried about that. Not worried about that. Not worried about that. But I'm also concerned with iodide deficiency. Hypothyroidism. Iodide. Okay. This one's a lot easier to explain than Graves'. With Hashimoto's, it's an autoimmune disorder where we just target and attack the thyroid. So no TSIs. We're just now straight up attacking the thyroid. If I start attacking my thyroid, how many secretions are going to be able to come out of there? Not a lot. So that's why you see decreased T3, T4. With iodide deficiency, you need iodide to make T3. You need iodide to make T3. What ends up happening is if you don't have iodide in your diet, your thyroid gets bigger, hence the goiter. Okay. Thyroid gets bigger. To comb through more blood. Your thyroid is desperate for iodide. If you don't have enough iodide, it gets bigger so it can try to comb through even more blood. So hence why, again, goiter happens with hyper or hypo. In the US, not very prevalent. Why? Salt. Salt, sodium chloride is fortified with iodide. And hey, guess what has salt in it in the US? Except recently. The whole popularity now of like pink Himalayan salt, kosher salt, sea salt, all of these salts are not iodide fortified. So we might see an emergence of this from clean, healthy eating. Okay. Now T3, T4 controls your metabolism. It's low. So what happens to your metabolism? Decreased metabolism. So because of that, you're looking at fatigue, weight gain, hair loss. You might see myxedema. Myxedema. So it's a type of edema. This is basically sugar and mucus coating organs. It's a sugary mucus mixture, not just fluid. Why would they have sugar built up on their organs? They're not burning it, they're storing it, and they're running out of places to store it. The myxedema coma is when your organs are so coated in the sugary mucus that they don't function anymore. The heart doesn't inflate, the liver doesn't secrete bile, pancreas doesn't secrete enzymes. Okay. So that sugary mucus can actually interfere with organ function. This is your periorbital myxedema. Okay, so it's interesting. Both hyper and hypothyroidism affect the eyes. However, with the periorbital mixed edema, you see these bags? These bags, these sacs are filled with mucus and sugar. Okay. That's your unique symptom there. So if I describe a patient with a goiter and recent weight loss, is that hyper or hypothyroidism? Weight loss would lead to hyper. If I say a patient has periorbital mixed edema, hypo. If I say a patient has a goiter, it could be either one. You need more clues. Okay. Very good. So, hello. I don't, with the whole health assessment, Lindsay talks about like velvety skin versus like leathery skin. I don't get into that. I just, because I haven't actually like seen it. So it's not, I'm not saying that it doesn't exist. I just don't think using velvet and leather are good descriptions. All right. Next one here, and then we'll take a break. Okay. Hyperparathyroidism. So, hey, guess what? You have excess parathyroid hormone. Parathyroid hormone. Does anybody remember what this does? It's the antagonist to calcitonin. So, yeah, it breaks down bones. So, what cells would they stimulate if we're breaking down bones? Stimulate osteoclasts. So, this is exactly what's going to happen on your exam. I'm going to say, hey, patient has hyperparathyroidism. What are you worried about? You could memorize what it is, but if you know what the original hormone does, you know what the effects are, right? If we stimulate osteoclasts, that's going to cause increase in bone crushing or breakdown. What's going to be released into the blood if you start crushing your bones? Increased calcium in blood or serum calcium. So, hey, look, you're looking at hypercalcemia. Nailed it. If you got a lot of calcium in your blood, you also probably got a lot of calcium where else? In the kidneys, in the urine, setting you up for Yahtzee. And hey, how are my bones? Pretty weak. Yeah, they're pretty like they're pretty flimsy. I'm gonna sit down and I might break a hip. Okay, that's what a pathological fracture is your bones are breaking due to some sort of disease. In this case, this hyperparathyroidism is disintegrating your bones. How do we fix it? Maybe vitamin D, but it's going to be like a huge losing battle here with the finding your class. Cut it out. Cut it out. Okay. Hypoparathyroidism. So if hyperparathyroidism causes bone disintegration, hypoparathyroidism, it's just, yeah, you're just going to be building bone because you're no longer inhibiting your or stimulating your osteoclasts. Okay. So this will decrease serum calcium levels. Anybody remember what that does to, I don't know, muscle contractions, skeletal muscle contractions? Calcium affects which part of the neuron? The threshold. Therefore, that's going to increase muscle contractions. So this person might have muscle spasms. Their muscles might become locked up. Okay. So a little bit of review there because that's pretty important. Cool. All right. So we're going to take a wee little break. I'm just trying to see how far we're going to get. Hopefully we should be able to finish. Okay. So as when we come back, it'll probably be a little bit faster. You know, have to run through diabetes pretty quick. I'm going to make some print off some of the paper copies of the endocrine packet. 11, you guys cool? We start at 11. Okay. Yeah. Whoop. Mhm. All right. So picking it up, we might run a few minutes late. Sorry, guys. I'm hoping I can get through diabetes quick enough. Okay. All right. So jumping into diabetes here. So we talked about diabetes insipidus. This is the other side of that slide. Talk about diabetes mellitus. This is what people are most familiar with. Okay. Usually some issue with glucose, something in there. You guys are probably familiar with type 1 and type 2, yeah? There's actually 1.5. They're proposing type 3. There's gestational diabetes. You're not responsible for those. Just talking about 1 and 2. There's a bigger world out there. Okay. So these are some common symptoms seen with both of them. Hyperglycemia. What's going on there? Too much sugar in the blood. Absolutely. Polydipsia. We talked about that, which is, what does polydipsia mean? Many thirsts. Polyuria, urination. Polyphagia, many eatings. Why would you eat a lot? Why do you eat? Because your hunger, yeah. Or stress during finals week. I already bought my family-sized Cheez-Its, getting ready for this. Hot and spicy. Hot and spicy. Fight me on it. Fight me on it. Weight loss. So this is actually a very interesting symptom here. Most of the time when you think about somebody has diabetes, you think of weight gain. We actually see weight loss and fatigue. Okay. Now, one of the ways we can measure long-term glucose control is the HbA1c. HB stands for hemoglobin. Okay. So this is used to monitor long-term blood sugar levels. So when you guys are nurses and I show up in your clinic or your hospital, don't ever choose me. Like out of a whole list of patients, don't ever choose me. I'm the worst patient you'll ever have. Because if I have diabetes, I'm going to lie to you. I can't afford those premiums. Are you kidding me? So when you test for blood glucose, it's usually a finger prick. You see the blood, how much sugar's in there, yeah? If I'm lying to you, I'm going to maintain my diet for the last 72 hours. So if you prick my blood, will my glucose be out of range? I won't be able to get away from this one here. This measures glycated hemoglobin, i.e. how crystallized, there we go, how crystallized that hemoglobin is. You guys remember how we talked about this idea of supersaturation? If you have too much of a sugar or calcium, it comes out of solution. Same thing with uncontrolled diabetes. If I have too much glucose in my blood, it starts sticking to my hemoglobin. It makes my hemoglobin look like rock candy. Okay. This gives you, give or take, about 3 months worth of data. This tells you how I've been doing for the last 3 months. Why 3 months and not like 6? Your blood only lasts 180 days, only lasts 3 months, give or take. Okay, very good. So this is how, again, we can see long-term monitoring versus just like today's monitoring. Okay. Don't know. The resting glucose. All right. So with diabetes mellitus, type 1, the relationship to insulin is that they are dependent. Why? Type 1, we have pancreatic atrophy and a loss of beta cells, i.e. type 1 diabetics, they don't have beta cells. No beta cells means no insulin. So, hey, they are dependent on it. They need to supplement with insulin, okay? But if we had more time, I would love to get into the ethics of insulin prices. It's crazy. Type 2 is insulin resistant, okay? Now, this is the textbook definition. I kind of think of it as a insulin tolerance. Again, this is just a me thing. Don't go out into the field and say like, oh yeah, you're insulin tolerant. It's me thing. The reason is because you're going to see an analogy here. I kind of equate this to an alcoholic tolerance. If somebody wakes up with 5 shots of tequila every day, what's their tolerance going to be like? Pretty high. Okay, so kind of keep that in mind because we're going to come back to that analogy. But type 2, years of hyperglycemia. Years. Okay. All right. So the way I kind of think of it is, remember, insulin allows you to suck in glucose into your cells, right? Imagine yourself trapped in a desert island, on a desert island inside of a cage. Just outside of that cage, you have food and water, but it's just outside of arm's reach. If you can eat that food, would you survive? If you could reach that food, would you survive? The food is right there, but you can't reach it. Okay, because insulin is what allows you to bring glucose into your cells. So in a type 1 diabetic, here's the glucose. The cell is right here. The food is right there. We just need to bring it from here to here. That's all we need to do. But we can't because we have no insulin. Okay. Type 2 diabetic, notice, hey, we got insulin and we got glucose. The food's there and so is the insulin. Insulin binds to the cell, but it's not enough. It's not enough. Going back to this idea of this insulin tolerance. If I have a very high tolerance, 3 shots of tequila, is that going to do anything for me? I need more to have an effect. Does that kind of make sense? Okay, so talking about type 1, there is some genetic stuff to it. It seems to be, it seems to manifest during another infection. So we kind of talked about autoimmune disorders when your immune system gets confused. Kid goes in for some sort of, I don't know, GI tract infection. They've been having diarrhea for 3 days. They come out, their pancreas has been attacked. Their their immune system attacks their pancreas and the foreign invader. Okay. It could be also non-immune, i.e., if I'm missing like half a pancreas, makes sense. What is the typical age of onset? It's a range. I'm not looking for a specific number. When do people typically find out that they have type 1 diabetes? Childhood. It can be late puberty. Okay. I don't know if anybody watches football. I don't watch football, but Cutler, a while back, professional athlete, right? He didn't get diagnosed with type 1 diabetes until he was a professional football player. Didn't know until I think after he left the Broncos. What? How can that be possible? This guy makes no insulin. Does anybody remember what mimics insulin? Muscle contraction. Muscle contraction. When you contract your muscles, that mimics insulin bringing glucose into your cell. Professional football player, how often do you think they're working out? That's why he never needed insulin. He was working out that much. So it can range, but typically childhood. Yeah. In theory, yes, but I think at some point they're going to find out when their blood sugar is like 16 when they go to bed. Mhm. All right, type 2 diabetes, much more common. Again, that 90%, don't need to know that fact, that number, but years of prolonged hyperglycemia. So typically, when do you guys think this would set in? Age of onset is adulthood. Again, we are seeing increased cases of pediatric type 2 diabetes, which is kind of sad. Okay, let's think about treatment here. So type 1 diabetes, what's the problem? No insulin. So what's the treatment there? Type 2 is a little bit more complicated. What would treatment be? Think about like the stereotypical thing you hear about when diabetics go to the doctor. What do you need to work on? Diet and exercise. Diet and exercise. Okay. We just talked about the exercise. Why would exercise actually help a type 2 diabetic? It doesn't create insulin, it mimics insulin. So, hey, you can have the same effects of insulin without insulin. Okay. Diet. What am I trying to restore sensitivity to? Insulin, i.e., glucose. Yeah. So with the diet, we want low carbs, high fats and proteins. This is, again, my professional opinion. This is the only time I would ever recommend the keto diet. If you do keto, go to you, like power to you. It broke me, almost lost every damn near relationship I ever had. Your brain runs on carbs, only carbs. Go you. Well done. Okay. So, sorry, getting back to it, guys, here, just because we're on time crunch. Okay. Type 2 diabetics, diet and exercise. Would I want to use insulin in their treatment? Now, think about the analogy I've been giving you guys. If I'm an alcoholic, I take 5 shots of tequila to get my day going. Are you going to treat my alcoholism with more alcohol? What would happen to my tolerance if you tried to do that? So, in an ideal situation, do we want to treat them with insulin? In emergency situations, absolutely. If they need insulin, give them insulin. But daily life, this is typically what we look towards. Okay. That's why I like that alcoholic example there of the idea of tolerance. That's the PCP's call. And we're going to talk about here in one more slide. You're good. You're good. All right. So you're going to see microvascular diseases with both type 1 and 2. Retinopathy, nephropathy, neuropathy, eyes, heart, brain, blood vessels. What kind of damage affected those? Eye, kidneys. I kinda. Yeah. Eyes, kidneys, heart, brain, vessels. That's your end organ damage. So somebody with type 1 and type 2 is at risk for end organ damage. Why? Elevated glucose causes vessels to harden. Elevated glucose causes your vessels to harden. What was that cause? Or what was that called when we're talking about harden? That's fatty plaque. Yes. Both of them are at risk for arteriosclerosis. Oh, sorry. Awesome. Okay. Now, if we notice infection, why do we see such advanced infections in diabetics? What loves to eat sugar? You got it. You got it. I'm just say bacteria there. Okay. Now, macrovascular disorders really only affect type 2, coronary artery disease, stroke or a CVA or PAD. Anybody remember these 3 diseases were a possibility from what other disease? Atherosclerosis. So here's the difference. Both of them are at risk for arterial. Athero is a type of arterial. Why is a type 2 diabetic more at risk for fatty plaques than a type 1 diabetic? Let's think about the diet. They have too much sugar. Now, in terms of foods, when you have foods high in sugar, they are usually high in, so diet, high in carbs and fats. Okay. So again, that's why a type 2 is more at risk for athero, but both of them are at risk for arterial. This is assuming that they have high glucose in their blood. This is assuming that it's poorly controlled diabetes. If they maintain their strict controls, maintain good ranges, can we minimize this risk? Absolutely. Okay. So acute conditions of type 1 diabetics. So this slide here, how to interpret this. These two conditions are more likely to affect a type 1 diabetic than a type 2. Okay. First up, hypoglycemia. What? Weren't we just talking about type 1 diabetics? Diabetics have high blood sugar. Why would a type 1 diabetic have hypo? Why would their blood sugar be low? Improper insulin administration. I'm just saying admin. Improper insulin administration. There's different types of insulins. You have short acting, you have long acting, you have intermediate acting. Okay. If I'm a diabetic, let's say I'm about to sit down and eat, I inject my insulin, and then my dog runs out the front door. I'm going to go chasing my dog. What did I forget to do? Hypoglycemia. Okay. Now, what's more dangerous, hypo or hyperglycemia? Hypo is more dangerous. Why? More dangerous than hyper. Now, don't get me wrong here. Both will kill a person. Hyperglycemia will kill a person, but a little bit slower than hypoglycemia because the brain needs sugar. Type 1 diabetics, if they don't monitor their blood glucose while they're sleeping, gets super low, they can start seizing. An awful experience for a significant other to wake up to. Okay. Another thing that can affect a type 1 diabetic is diabetic ketoacidosis, DKA. Okay. Really, what I'm concerned with is the last point here. Breakdown of fats and proteins. When a person breaks down fats and proteins, that makes ketones. So when you take in fats, you take in proteins, you make ketones. Normally, these ketones, you just pee them out. No problem. Why would a type 1 diabetic have excess ketones? It's the only thing they can metabolize. Only macros they can metabolize. Can a type 1 diabetic metabolize carbohydrates? No, just fats and proteins. If that's where their energy is coming from, they're building up more ketones. Okay. Again, they're making more ketones than they can pee out. You might see DKA present in the breath. You might hear like it's a fruity breath. Anyone want to weigh in on that? I don't think it's actually fruity. I think it smells a little bit more like acetone, but different strokes for different folks. Yeah, that's a thing too. All right. So some common complications. This means it's shared between 1 and 2. My recommendation, be able to explain these. Be able to explain these because of either type 1 or type 2. So take, for example, again, we'll just say diabetics in general. Why would a diabetic always be tired? Well, the glucose is in their blood. Does it ever get into their cells? Ever get into the brain? So I'm going to say inability to suck in glucose. So if I'm a diabetic and type 1 diabetic, for example, I eat a cupcake, where's all that sugar going to go? It goes into my blood, which goes into my urine, and I pee it out. Did I absorb any of that cupcake? No energy. Okay. Frequent urination, that right there, it's because you're trying to constantly dilute your blood. Your blood's too concentrated. So you're drinking a lot of water, which means you're urinating a lot. Okay. Why would I all of a sudden lose weight? Shortage of nutrients, but I ate the cupcake. What's wrong? I didn't absorb it. I didn't metabolize it. Okay. Wounds that won't heal. That's weird. Why were my wounds taking longer to heal? Decreased perfusion due to what? Fusion. I'm going to say due to the arterio because it could be arterial or athero. Arterial leads to decreased perfusion. So, hey, guess what? Less perfusion. The balloon animal is not getting inflated. That's the type of humor you're in for. I'm sorry. Always hungry. Again, I'm going to eat this cake. Am I going to absorb it? Okay. Blurry vision, we're going to talk about. This is where we're going to talk about. Thirsty kind of feeds into that. Infections, bacteria, yeast, love, sugar. Okay. Oh, sorry, guys. I forgot to mention. With the DKA, why is a type 2 less likely to experience DKA? Type 2 diabetes mellitus still has some response to insulin. Type 2 diabetics still have some response to insulin. So remember how I told you this idea of tolerance? I need 5 shots of tequila to get me going. On some days, some lucky days, 4 shots is enough to get me going. Okay. So it's not that all the cells have become intolerant or tolerant to insulin. Most of them have. But because some cells still respond to insulin, that's enough to prevent DKA. Okay. So less likely to have DKA. Okay. All right. So this is personally for me one of the terrifying things about diabetes mellitus. Okay. Remember we talked about arteriosclerosis, thickening and hardening. The blood vessels get harder, less blood. Less blood, what do we call it? Ischemia leads to. Okay, so what happens is at the retinas, there's less blood, becomes ischemic, becomes hypoxic. Parts of the retina begin to necrose. Okay, with diabetic retinopathy, there's holes in your retina. Your vision starts turning into a Swiss cheese. You're unable to focus. Now we understand this. Let's just say, assume I get retinopathy from my diabetes. This is enough to scare me. I start exercising. I start changing my diet. Is this reversible? That necrosis is irreversible. It's permanent. Again, this is what's terrifying to me. You literally get to watch as the lights leave your eyes. That's terrifying. Okay. Now, with diabetic peripheral neuropathy, okay, here's your tissue. You got blood, you got nerves. Awesome. With arteriosclerosis, what happens to your blood vessels? They start hardening, and your blood vessels, do they perfuse as far? Your blood vessels pull back. So let me say arterio causes blood vessels to retract. Arteriosclerosis causes your blood vessels to retract. So do I have as much blood going into this area? What other structures are in your skin that need constant oxygen? Your nerves. Your nerves need constant oxygen. If there's no blood flow, what's going to happen to your nerves? Ischemia, hypoxia, your nerves will retract. So this is what I'm trying to get at here. Diabetic peripheral neuropathy. Yes, the nerves retract. The question is, why? Diabetic patient is going to come to you and ask, why can't I feel my foot anymore? What's your answer? The blood vessels have receded. Okay. Now I receive an injury. Would I know that I had an injury? So by the time I find it, it's going to be pretty advanced. What does that mean for healing then? Why can't I heal? Why do I have a prolonged decreased perfusion due to the arteriosclerosis? So one of the things, so ulceration, diabetics check their feet. You guys went over this in health assessment. One of the things you see with diabetics is successive or consecutive amputations where we take part of a toe, then we take the toe, then we take part of the foot, then we take the whole foot, then we go above the ankle, below the knee, above the knee. All right, so a little bit of humanity here. Back in the day when I used to do a bunch of martial arts, my grandmaster was an 8th degree Taekwondo master that trained in Korea. The guy had diabetes, severe diabetes. He had both of his legs amputated. Now, Taekwondo is a martial arts where it's nothing but legs. Why? You'd think that somebody would, have a little bit of self-realization. Maybe you couldn't feel it. Maybe you couldn't feel it. You remember what we said about eating disorders? What did eating disorders all come down to? A lack of a feeling of control, right? If I have diabetes and I know I'm going to lose my feet, I know I'm going to die. I'm going to go out on my terms. I'm going to eat what I want to eat. I'm going to feel the way I want to feel. I know I'm going to die anyhow. That mentality right there. Remember that idea of control. That's sometimes one of the most difficult things working with diabetic patients. They're not listening to you because it sounds like you're taking away their control. Okay. So a little bit of humanity there when you guys are starting to work with patients. All right. Cushing disease, I'm going to kind of power through this here because I'm sorry, guys. I don't mean to keep you late. Cushing's disease, too much ACTH. Okay. Leads to too much cortisol. Now, there's Cushing's disease up top and Cushing's syndrome. I won't discern between them. I'm just going to call it Cushing's. Cushing's is, again, the idea of, let me just highlight this, excess cortisol. Excess cortisol. What was the issue if you guys in nursing school had too much cortisol? Released by stress. It's an immunosuppression. So it's a suppressor. So somebody with Cushing's has immunosuppression. What else? What happens to their metabolism? Oh, yes. So what kind of symptoms would you anticipate? Metabolism. Okay. So I'm just going to put an X through syndrome. Again, we're just going to call it Cushing's. Okay. So you're going to see increased weight gain. Okay. Usually it's around the abdomen. Okay. That's some severe weight gain. Yeah. This is actually called moon face. Don't go up to a parent and say, hey, your kid has moon face. Right. But I'm just saying, like in textbooks and all that kind of stuff. There you go. Addison's. So Addison's, the way I kind of remember this, Addison's, you have to add something. Addison's is an issue with decreased cortisol and decreased aldosterone. So during break, what's going to happen to your cortisol levels? Is that going to kill you? So with Addison's, what is the hormone you're going to be concerned with? Aldosterone. What does aldosterone do? Aldosterone causes sodium and water reabsorption and potassium secretion. Okay. So I don't have enough aldosterone. What happens to reabsorption of sodium and water? Decreases. I'm not reabsorbing it. Therefore, what's happening to urine output? I'm not reabsorbing it, so it stays in my urine. It goes up. So you're going to see increased urine output. Okay. But you're also going to see decreased potassium secretion. Where's the potassium going to start building up? In the blood. Because secretion, remember, you're going from blood to urine. If I am not secreting it, I'm seeing increased potassium in blood. Good or bad? Why? Cardiac dysrhythmias. Sorry, I tried. Spelling's not my strong suit. Okay, so the big issue there was that increase in potassium. Okay, you'll have less sodium, but again, the potassium is what's going to kill a person first. Okay. Conn's disease is hyperaldosteronism. So now you're reabsorbing too much sodium and reabsorbing too much water. So let's talk about electrolytes. Okay. What's going to happen to potassium levels? They're going to decrease. Why? Decreased potassium due to increased secretion. Okay. What's going to happen to sodium levels? Now, when you reabsorb sodium, what else do you reabsorb? So if you take one sodium and one water, will your concentrations change? No. So we see no change in sodium, and that's the tricky part. Am I going to change sodium concentrations? No, because I'm also reabsorbing water with it. So due to increased water reabsorption. Okay. It's not just water, it's also with sodium because we're pulling two at the same time. Sodium levels won't change. So it's neither diluting or concentrating. You're just going to have more fluid in your blood. Okay. Now, this is your DHEA. Does anybody remember DHEA? When women have DHEA, it gets converted into testosterone, males converted into estrogen. Feminization is where we start seeing DHEA converted into estrogen. So who would that affect, males or females? So males would see feminization, okay, hypogonadism, breast development, decreased growth, okay? Virilization is when DHEA gets converted into testosterone. Therefore, that's going to affect females. Okay. So really quickly here, here's a patient. Is this virilization or feminization? Look at breast development. Do we have more or less? So that's going to be virilization. So this is a female with too much DHEA getting converted into testosterone. We have a lack of breast development and increased muscle. That's your testosterone there. Okay. I don't know why it's one-sided. It's just so drastic. I have no idea why. Now, this one here, pretty straightforward. Pheochromocytoma. There we go. Or a chromaffin cell tumor. Hey, you have a tumor on your adrenal medulla. Your adrenal medulla secretes what? Epi, norepi. What's the issue if you secrete too much epi, norepi? Constant fight / flight. Why is this a bad idea? You're looking at a heart attack, hypertension, chest pain, tachycardia. Your heart's going to give out. Okay. All right. So that's technically what I have for you guys. If you guys want, I know I'm running late. I'm sorry. I'm going to recap everything. I'm going to put the organs down along with the diseases that we covered just to kind of help organize stuff. But if you need to bust out or anything like that, totally fine. I'm sorry, this one took a little bit longer. I need to talk faster. All right, so we started with the hypothalamus and the pituitary. Okay, we're talking mainly about the infundibulum there. We had pan, hypo, pituitaryism, and hypopituitaryism. Okay. Say the infundibulum. We talked about the anterior pituitary in regards to growth hormone. If you have too much or too little during childhood, Okay, that's your gigantism versus dwarfism. And during adulthood, you had acromegaly or metabolic syndrome. Okay. The other hormone that we talked about from the ant pit was prolactin. And we only talked about prolactinoma, i.e., you had too much prolactin. Okay. From the post pit, we talked about anti-diuretic hormone. We talked about too much or too little. If you have too much ADH, it's SIADH, syndrome of inappropriate antidiuretic hormone. Too little, it's your diabetes insipidus. Okay. We also talked about your thyroid. We talked about T3, T4. If you have too much hyperthyroidism, what was the specific hyperthyroidism we focused on? Graves. Too little, you had Hashimoto's / iodide deficiency. Now, the purpose behind me doing all of this here, not all of these diseases follow hyperthyroidism, hypothyroidism. Some of them are named after people. So that's just to help you guys out because it can go either way on the exam. Okay. Then we had parathyroid with your parathyroid hormone. Too much, too little. It's just hyperparathyroidism or hypo. It just looks super long. Hyperparathyroidism versus hypoparathyroidism. Okay. Oh, photos? Yeah. If anybody just wants to take a picture of that, that's totally fine. Okay. Second part of lecture, we talked about the pancreas. Okay, with the pancreas, you got type 1 diabetes mellitus, type 2 diabetes mellitus. Okay, your adrenal cortex, aldosterone, cortisol, DHEA. DHEA, we talked about feminization versus virilization. Okay, aldosterone too much, too little, cortisol too much, too little. Too little aldosterone, Addison's. Again, Addison's was 2 of them. Okay, cortisol caused Cushing's. So that's the way I remember this. Cortisol is the C's, the Cushing's. While too much aldosterone, that's your cons. Okay, cortisol, Cushing's. Think about those cheeks, moon face, cushions. Last one was the adrenal medulla with too much epi / norepi. Okay, that's your pheochromocytoma, etc. Sorry, guys, this one went on a little bit longer. Okay. So tomorrow, 8 a.m., you guys' quiz, endocrine phys, endocrine path. You got homework tonight. 95%. Yeah. Yeah. Okay. Thank you, guys. Thanks for hanging in there.